to make sure that you don't need anything from me, were you able to get all of the speakers to join?
Yes, all of them are in. They're all in, and we're going to be starting in the next minute or so. So thank you so much, Carly, for your assistance. If you're able to just be on the line for sort of the beginning part, that would be great.
Yeah, that's great. That's great. No problem. I'll be here.
Fantastic. Thank you. Hello, everyone, and welcome to today's webinar. My name is Erica Stutt. I'm a Senior Associate with the FP 2020 Secretariat, and I will be moderating today's discussion. On behalf of the Secretariat, I am happy to welcome you to this important conversation. FP 2020 commissioned this report, Contraceptive Discontinuation, Reasons, Challenges, and Solutions, at the recommendation of the Performance Monitoring and Evidence Working Group. One of the goals of the Performance Monitoring and Evidence Working Group is to identify a research agenda that will allow FP 2020 to obtain the knowledge and insights necessary to achieve our goal. Our goal, of course, is to reach an additional 120 million people with modern methods of contraception by the year 2020. Because FP 2020 seeks to facilitate access to quality family planning programming for the millions of women and girls with an unmet need, and because it also seeks to do so in a way that respects their rights, we must have a deep understanding of the dynamics of contraceptive decision-making. And this includes having a good grasp on reasons for contraceptive discontinuation. The interventions that are outlined in the report will help FP 2020 support countries to implement pertinent interventions to strengthen family planning programming. Today, we are grateful to have the two authors of the Contraceptive Discontinuation, Reasons, Challenges, and Solutions report with us. They are Dr. Ian Askew of the Population Council's Kenya office and Dr. Sarah Castle of Palladium, London. Also providing insights into their work in addressing contraceptive discontinuation are Dr. Shamul Koli Hussain of the Ministry of Health and Family Welfare in Bangladesh and Dr. Anirudh Jain of the Population Council. Before I turn the presentation over to the speakers, I would like to note that we will have a Q&A session during the last 10 minutes of the webinar. So that's approximately beginning at approximately 8:50 a.m. Eastern Standard Time. I encourage you to join the Q&A by sending questions for our speakers throughout the presentation, and you can do that in one of two ways. First, you can type your questions directly into the Q&A box that you see here on your webinar interface, or you can email your questions to my colleague, Sarah Meyerhoff. Her email listed here is smeyerhoff@familyplanning2020.org. Please also be reminded that all participants except the speakers have been muted in order to reduce background noise. This webinar will be recorded and made available on our website. And that address, by the way, for all things discontinuation, including the report, is listed here, www.familyplanning2020.org/discontinuation. And now I'd like to pass over to Dr. Ian Askew. Ian is the Director of Reproductive Health Services and Research with the Population Council.
Thank you, Erica. Good day, everybody. Good evening, afternoon, or morning, wherever you are. And thanks for joining this webinar. Sarah and I are very happy to have this opportunity to present the results from the survey, and we'll be also happy to answer any questions you have about the report after you've heard the key findings. Can I have the next slide, please? Just to give some background to the report, which, as you heard from Erica, was requested and commissioned by the Performance Monitoring and Evaluation Working Group. Discontinuation has been identified as a critical issue, not only for Family Planning 2020 as an initiative, but globally for all those working in the family planning area. This first slide shows a number of important characteristics that we're already aware of, and that stimulated the further analysis excuse me, that we undertook. Most importantly, we know already that anywhere from 12% to 47% of women who are using contraception because they don't want to become pregnant do stop using a method within the first year, and by 2 years, almost half of women have stopped using. We also know that among women who have discontinued, who have an unmet need, over 1/3 of these, 38%, have an unmet need because they've previously discontinued using a modern method of contraception. Furthermore, we know that most women who discontinue their method do so without consulting a healthcare provider, and so there are major challenges to family planning programs in trying to reach and address the needs of women who have discontinued. It goes without saying, it's fairly obvious, but it's important to reiterate that women who use long-acting methods such as IUDs, IUS, or implants are less likely to discontinue for reasons other than wanting a pregnancy. And so this has important implications for the method mix available. And in conclusion, the reason for this review and analysis was because the dynamics around contraceptive discontinuation do need to be much better understood if FP 2020 is to achieve its goal of reaching 120 additional women. Our colleague Andrew Jane will say a bit more about this after the presentation and some of the arguments for this. But it's important to bear in mind that contraceptive discontinuation is not necessarily an indication of a program failure. It may, if it's followed up with women using another method after they've discontinued and is in effect a switching of methods, then it's not necessarily a problem. But we need to understand when discontinuation happens without continued use of protection and women are at risk of an unwanted pregnancy, then that's when the challenge for programs really happens. Can I have the next slide, please? The review was organized around 4 broad questions, which are on the slide here. First of all, what are the reasons for discontinuation other than wanting to become pregnant? And what can be done about these reasons? Do we understand why the reasons are and which women discontinue for which reasons? The second question we addressed was, do these reasons vary by user characteristics, by the characteristics of the women themselves? Or do they vary by the different contexts in which family planning services are offered and in which they're used, including cultural, familial, and relationship characteristics and contexts? And if they do differ, why would this be? Thirdly, are there specific service delivery or method attributes that are associated with higher or lower discontinuation rates? In other words, are there particular ways of offering family planning services or particular methods of family planning that tend to be associated with either higher or lower levels of discontinuation? And finally, drawing from this, we wanted to try to find out, are there any so-called best practices? Are there certain approaches, programming approaches, that can prevent unnecessary and unwanted contraceptive discontinuation, and that could potentially be scaled up and used more widely to help reduce levels of unwanted contraceptive discontinuation? Next slide. The methodology, what we did, we undertook primarily a desk review which was undertaken, and I'll use the word rigorously rather than systematically. This was not a systematic review that followed Cochrane-type procedures, but it was rigorous in that we used several search engines to find the literature online, in addition to our own knowledge of the literature, using the keywords that you see there. We searched up to 25 years ago, because this is not a new literature necessarily, although bringing it together and trying to interpret it is a current challenge. We also talked to a number of experts at both implementing agencies and donor agencies to get their perspectives and to ask them for further literature that we may be able to use. We consulted a number of researchers who have done in-depth analyses around reasons for discontinuation, including the authors of several key analyses of DHS data, which have formed a major part of this analysis. The draft findings from our review and our analyses and interpretation were shared with the Performance Monitoring and Evidence Working Group. And the members of this working group provided extremely important insights and thoughts into the analysis, and we went back and reworked some of the data, reinterpreted what we'd provided, and came up with a second version, which was much improved based on their inputs, and which is what we're presenting today. If we could have the next slide, I'd just quickly like to introduce my co-author in this venture, Sarah Castle. Dr. Sarah Castle is a long-term expert in this field. She's done a huge amount of work around family planning and population issues more widely. Sarah spent a long time living and working in West Africa, and particularly Francophone West Africa, where she developed a lot of expertise, particularly around sociocultural aspects of contraceptive use. On her return to the UK, she has worked full-time as a consultant and done numerous consultancies with many international organizations, looking at program evaluations, stakeholder analyses, developing strategic plans, and the like. Sarah currently works for Palladium, where she's recently joined them in their London office, and so is now taking another turn in her career with that way. Sarah will cover three broad aspects. First, she will provide an overview of the dynamics of discontinuation. Secondly, she will review some of the key programmatic strategies that we discovered. And thirdly, she'll summarize what we've learned and suggest some evidence gaps that remain as we go forward. So Sarah, over to you. Thank you.
Thank you very much, Ian. Can you hear me?
Yes.
You can hear me?
Yep,
Good. Thank you very much. So could we have the next slide, please? So as Ian explained, we did reviews of the literature, including some very important work done on DHS data by Ali, Clayland and Shah from 2012. I won't sort of read out the details of every tiny bit of the slide, but as you can see, the median duration of use is much higher for IUDs compared with other methods. We don't have data for implants with this particular analysis because it was using data sets when implants weren't so widely used, and in fact that's probably a gap in the research to know exactly what the median duration of implants is, because we're kind of assuming that it has a similar duration or a longer duration anyway than short-term methods, and like the IUD, it needs a provider to remove it. So I think on this slide it's worth noting the longer duration of the IUD, generally because women want to stop childbearing altogether and because they need somebody trained to remove it. Thank you. Next slide, please. So on average, a woman will use a contraceptive method for 20 months for all methods. 38% of women discontinue by 12 months, 55% by 24 months, and about 2/3 by 36 months. 13% of IUD users will stop within 12 months. And as I say, there's limited data for implants, which we'll probably be able to rectify with more recent DHSs. Anyway, discontinuation for non-pregnancy related reasons. So remember, we're talking about discontinuation, meaning that a woman has discontinued her method, but she still has an unmet need for family planning. She does not want to get pregnant. So the non-pregnancy related reasons include reasons related to the quality of the service environment, And we'll talk a bit about this later, about the different elements of service quality, including, for example, counselling about side effects. 1/5 discontinue for method-related issues, and 1/3 discontinue because of side effects or health concerns. Next slide, please. So adolescents aged 15 to 19 are more likely than women aged 20 years and above to have shorter periods of consistent contraceptive use, higher use failure rates, 25% higher than older women, and a greater likelihood to discontinue for reasons other than pregnancy. So the reasons can include stigmatization and provider bias, limiting access or to resupply or switching. So there's some evidence to show, for example, that stockouts have a bigger a bigger sort of impact on adolescents who get more irritated by the fact their method of choice isn't available and might just discontinue rather than seeking another method elsewhere. There's a poorer understanding and acceptance of side effects, and I think almost universally one of the problems is that adolescents in particular are very afraid of irregular bleeding patterns and that think that this might lead to later sterility in marriage. And of course, in societies where women's status is contingent on their fertility in marriage, this is a very, very worrying thing for them. And I think it's indicative that quite often contraceptive decision making amongst adolescents in the here and now is contingent on what their sort of aspirations and fears are with regard to the future. So somebody's current decision making might be affected by how she thinks that's going to affect her fertility in marriage later on. I think that's a very important point to make. And then married adolescents are under familial pressure to conceive almost immediately on marriage. They have to improve their fertility, but then we need to get the sort of spacing between first and second births sorted out by decent postpartum family planning, which is perhaps somewhat of a challenge somehow. Next slide, please. Oh my God, can you not hear me? Hello? Next slide, please.
We can hear you.
Sorry, can you have the next slide, please? Oh, sorry. No, you've done it. So the main challenge is amongst women restarting short-acting methods before their menses return. So there's double or redundant protection while breastfeeding, and the likelihood of discontinuation at 12 months may or may not be higher. So starting a long-acting method following pregnancy reduces the likelihood of mistimed or unwanted pregnancy. So again, it's this business of having services orientated to do postpartum family planning. And there's also quite a lot of evidence to suggest that male engagement around this period is extremely important to continued use. So, for example, in Egypt, women living in communities with male engagement were using a method at 9 months compared with women in the control communities. So, makes the case for having men involved in family planning decision making. Although there is also, of course, an issue of clandestine contraceptive use in regions of very low prevalence, such as Francophone Africa, which is for a different discussion, but I think it's good to bear in mind. Next slide, please. 3 months after discontinuing a method because of the method-related reasons, the proportion of women switching varies widely. So I think this is a very important phenomenon which we tried to discuss in detail, is whether women who just discontinue full stop or women who actually switch to use another method. And the switching, of course, is contingent on there being a decent method mix. So we know that the majority who switch start to use a modern reversible method. And in countries with high levels of switching, about half will start using IUDs, but 1/5 switch to traditional methods. And switching is lowest in sub-Saharan Africa and mostly to a hormonal method. Sub-Saharan Africa being a case in point because there's so many women who prefer injectables, and second of all, the method mix is usually not great. But we discussed this in the paper. Next slide, please. So switching, especially immediately, reflects a woman's ability to determine her preferred method. But switching requires an availability of and access to sufficient method mix to provide a choice of alternatives. And some important work by Ian and colleagues found that one method can decrease adding an additional method can decrease discontinuation by 8 percentage points. And switching between types of hormonal method is common. So among women not switching within 3 months, 3 to 20% become pregnant within 3 months. And it's also worth noting how those births are defined as wanted or unwanted, because we know that people in post hoc fashion say that births are wanted when in fact they might not have been. And then 5 to 38% become pregnant by 12 months, and substantial proportions report these as wanted. Thank you. Next slide, please. So programmatic strategies to reduce discontinuation. Next slide, please. Programmatic strategy 1, to improve service quality. So 7 to 20% of women discontinued for reasons related to the quality of the service environment. And 40 to 60% of the overall discontinuation rate reflects decisions based on the quality of care. So a Cochrane systematic review of quality of care showed a substantial effect on continuation rates. Just using the case of Senegal here, for example, in Senegal, women receiving good quality of care were 1.3 times more likely to be using a method at 18 months. What we gathered from our research or review was that no single element of quality of care will influence the continuation rates. And there's been studies, I know, in the Philippines and elsewhere looking at the quality of counselling about side effects, sort of provider-client interactions, and not one single element alone can explain continuation rates. I'd also like to introduce the idea, which I don't think we mentioned in the slides, is that there's been an assumption up to now that a lot of discontinuation is deliberate, and that people make a conscious choice to discontinue their method because they're afraid of side effects or whatever. But I think when we review some of the evidence, particularly relating to adolescents, we find that actually there isn't an intentionality about it, and they're a bit ambivalent, and people kind of don't really mean to discontinue. It's just they can't go back to the provider because either they're not there, or they're feeling stigmatized, or the time and the opening time and the place doesn't suit them, and so they just sort of fall off and happen to discontinue. But it's not a deliberate decision, and I think that also is a subject for further research looking around the intentionality of contraceptive discontinuation, which requires more qualitative work probably. Thank you. Next slide, please. So the programmatic strategy 2, service providers may believe that they are better qualified to choose the most appropriate method for their client, and or have personal preference toward or against certain methods. So again, this provider bias, which might be related to providers believing that LARCs, long-acting methods, aren't suitable for people who've never given birth, or believing that young people shouldn't have sexual activity in the first place. They might impose their inappropriate values and beliefs, and resulting in stigmatization, so that people discontinue, or young people in particular discontinue, because they can't face going back to the clinic for a lecture. And providers may be biased if they receive financial or other performance-based incentives associated with providing certain methods. Next slide, please. So eliminating stockouts, programmatic strategy number 3, up to 5% of discontinuation is due to stockouts. The stockouts reduce switching opportunities, switching being the operative word. I mean, I think one of our conclusions is that we really have to support, first of all, continued use, and second of all, switching. Stockouts are attributable to funding shortages, regulatory hurdles, and poor forecasting procedures. Some qualitative work from a colleague in Rwanda, for example, noted that although nurses and midwives had undergone pre-service training in the kind of technical aspects of their work, they had absolutely no idea how to reorder stocks when they were used up. And so there's all kinds of pre and in-service training issues, I think, related to just the actual process of reordering, which needs to be made more familiar to people actually out in the field. And then Senegal's informed push model appears to have virtually eliminated stockouts, but further research is needed to determine whether it has reduced discontinuation. And in fact, Senegal in that sense provides a kind of natural laboratory setting. If it really has no stockouts, or very limited numbers of stockouts, it would be very interesting to do some more research to find out what other issues apart from stockouts are leading women to discontinue, particularly somewhere like Senegal, which has made such advances in overall CPRs in recent years. Okay, next slide, please. So programmatic strategy 4, increase access through multiple service delivery options. We were looking at population level measures of the continuity of use, including the DHS, the PMA 2020, health technology, and the demographic surveillance systems. Of course, to note, I think the point that Ian made earlier on is that most women discontinue at home. They don't discontinue sort of following an appointment in the health system, and so this is very tricky, of course, for follow-up. And there are very few programs which can afford or implement individual client tracking, Mary Stopes International, of course, has its click system, which does do this, and can hopefully enable people to follow up those who don't reappear, for example, for re-injection. There are client-held medical records, which are problematic. I was just in Mozambique last week, and these gave people great problems with regard to confidentiality. The young people thought that the medical records weren't confidential, and that put them off going for services. The DHIS2 shows potential for tracking individual women, and then there's mobile technology and mHealth, which has been very, very well developed now by PSI and others, which not only allows access to contraception through vouchers and stuff that are delivered by mobile phones, but enables them to track the demographic, socioeconomic profile of their users. But of course, mobile technology only works where you have a mobile network, and that can exclude a lot of rural areas. Thank you. Next slide. So this is our theory of change, which is detailed more in the report for reducing discontinuation. As we just described, there's a number of issues under the health system elements. For example, eliminating stockouts, having an adequate method mix, sufficient training and a supportive policy environment, which might include, for example, task shifting down to lower cadre staff for LARC insertion. And then service quality around comprehensive and balanced counselling, eliminating provider bias, the management of clients coming late and for resupply, and the engagement of male partners if appropriate, because I don't think that's always appropriate in low prevalence settings where women might be using secretly, which isn't everywhere, but it is Francophone Africa. And then a socio-cultural understanding of the interpretation of side effects and misconceptions, and then this business of intentionality and motivation. And I think it's just very important to understand that for many people, their contraceptive decision making, as I was saying, is not a function of their current need, and particularly for young adolescents, it's related to their perception of how they will be perceived in marriage, and the slightest risk of becoming childless, because they believe the side effects can cause sterility, is a risk that often they're not prepared to take. And then the outcomes would be identifying the discontinuers and support to restarting or switching, and then identifying the users and supporting continuation, which I think is often neglected in programs. Programs are very orientated around recruiting new users, but attention also needs to be given to supporting those who are currently using. And then underneath, you'll see we have a bar which recognizes the importance of individualized client tracking and the feedback for improved management. So all things in relation to programmatic operational issues, stockouts, etc., should be constantly monitored and feedback given so they can be rectified. Next slide, or is that we're coming to the end? Next. Oh, sorry. So then there's evidence gaps and further research. So some further some recommended actions need no further research. So, for example, informing people of the real reasons and implications of side effects and managing them in an appropriate way. And some recommendations should be supported by the implementation research to ensure appropriate configuration within the program and socio-cultural context. So this might look at actually increasing or improving, method mix down at a community level and looking at the implications, for example, of task shifting or something like that. Some interventions need further testing using quasi-experimental designs to determine their effectiveness in various contexts and for different populations, because we know that switching isn't heterogeneous across different, isn't homogeneous across groups. There are different subgroups, such as adolescents, who have a greater propensity to stop. And then a better understanding of the socio-cultural context and decision-making process amongst various populations that would inform program design to reduce discontinuation. So amongst that could be better understanding the idea of intentionality and what exactly is in the minds of people who didn't really mean to stop, but they did. And then looking again at kind of the sort of gender and power relations around stopping and starting, for example, in the male perspective, and again understanding the whole issue of side effects. Those are just examples. So the next slide, please. Or is that it? Right. Okay, so I think I'm done now.
Great.
Look forward to your questions. I hope it was clear.
Thank you, Sarah. Yes, and that's a great reminder that if anyone has questions along the way, you can definitely type those into the Q&A box, and we will address them in the last 10 minutes of the presentation. So now I'd like to turn over to Shimul Koli Hossein. Shimul is the Program Manager, A and RH, for the MCH Services Unit of the Directorate of Family Planning, Ministry of Health and Welfare in Bangladesh. So Shimul, we'll pass over to you.
Hello everybody, can you hear me clearly?
Yes,
Hello?
we can.
Yes, we can. Okay, thank you. Next slide. My presentation is on insight on progress and challenges in reducing contraceptive discontinuation in Bangladesh. Next slide. Next slide, please. Bangladesh is a hugely populated country with 160 million of populations residing in 55,126 square mile areas. So, though Bangladesh has achieved tremendous progress in health and population sectors, but still our growth rate is high, though it has decreased from 2.4 to 1.37% over the last 30 years, but still high in Asia. Next slide, please. Next slide, please. The population densities of Bangladesh is 1,203 people per square kilometer area, which is very high if you compare to other countries like China, India, and Pakistan. So we are really burdened with populations. Next slide, please. This slide shows the trend in CPRs and total fertility rate. You can see that in last BDHS study in 2014, the CPR is 62 and TFR is 2.3 per woman. And you can see that the TFR has stagnant over the last two BDHS survey, which is 2.3 child per woman. So it is a concern for family planning programs in Bangladesh. Next slide, please. These are some administrative divisions of Bangladesh. We have 7 divisions: Borishal, Chittagong, Dhaka, Khulna, Rajshahi, and Rangpur and Sylhet. You can see from this bar diagram that the TFR has different in different geographical area. In Rajshahi and Rangpur divisions, TFR is lower than the national level. That is, in last 2014, it was 2.1 in Rajshahi, and in Rangpur division 1.9 children per women. So it is quite below the national level, but we can see that the other divisions, especially the Sylhet and Chittagong division, TFR is quite high. So this is the geographical variations of total fertility rate is also a concern for family planning programs in Bangladesh. Next slide, please. Contraception, according to our BDHS study, the percentage of users stop using methods within 12 months of starting the use is called the contraceptive discontinuation rate, which is a key concern of family planning programs, which is very high in Bangladesh. In last BDHS study, it was 30%. And this discontinuation rate contributes substantially to unplanned pregnancy. Those who are discontinued, we have seen from this the Sarah's presentation, those who discontinue contraceptive become pregnant within 3 to 18 months of whether it is unplanned or planned pregnancy, they become pregnant. So next slide. This is the trend of discontinuation rate. It was high as 49% in 2014 and increased in 2017 because that time we had a contraceptive stock out, and gradually, though it is decreased but not the optimum level. In 2014 it was about 30%, though we targeted 2016 and the targeted discontinuation rate is 30, but it's still too high, and we targeted to decrease this rate to 20% within 2021. Next slide, please. These are some discontinuation rate of some other methods of family planning. Obviously, the LAPM's discontinuation rate, obviously it is lower than the short-acting methods, and the highest discontinuation rate as observed in condom user, among condom user and pill user. The injectables user also discontinue substantial proportion of injectable user discontinue contraceptive, almost one-fourth of user discontinue injectable within 12 months of use, and it is really surprising that even the implant user discontinue the contraceptive 6.5%, because the implant user needs to go to the service providers. So it is really surprising that they 6.5% user discontinued implant. Next slide, please. These are the trend in current use of contraceptive methods. We can see that in BDHS 2014, the pill user is 27%, and condom user 6.4%, injectable 12.4%, and implant 1.7%, IOD 0.6%. That is, IOD users has decreased from the previous survey, and sterilizations 4.6 and male sterilization 1.2. Altogether, LAPM share only 8.1% of total users. So it is really a great concern of family planning programs in Bangladesh. Most of the people want to use the short-acting method. Next slide, please. These are the 12-month contraceptive discontinuation rate by reason. We can see that the method failure is one of the cause, especially for those who use pill, and the side effect or health concern is especially for injectable user is main concern for discontinuation, and for the other method related reason, that means they want to switch to other methods, is 5.8% for condom, and also we can see that the other fertility reason is quite high, 6.6% for oral contraceptive pills. So we can see that there are different reasons for contraceptive discontinuations, and if you can see from any reason, the highest reason of contraceptive discontinuations, obviously the condom user, discontinue most, and then the pill, and then the injectables, and implant user also 6.5%. I also mentioned it previously. Next slide, please. So why people discontinue contraceptive use? Actually, it is because of 3 C's. The first one is the client selections. So the wrong client selections is one of the reason, because we can see from Sarah's slide that most of the providers, some of the providers is biased to one method, so they imply their choice to the client, and say if the clients need IUD, they either give implant, or if the client need implant, they give IUD. So the wrong client selection is one of the cause, and the faulty screening of client is also a important cause for discontinuations. And counseling, low quality of counseling, that is if the providers do not give adequate time, or the provider is not skilled on counseling. So these are the main another important reason for contraceptive discontinuation, because if we counsel the client, they will the compliance will be better. And obviously the complications is one of the reasons for discontinuation. Complication of contraceptive, especially due to the wrong client selections or low quality of infection prevention, is one of the important cause of discontinuation. Next slide, please. In Bangladesh, unintended pregnancy remains a significant public health concern. A high proportion of mothers reported, 28%, reported unintended birth, 15% is missed times, and 13% unwanted. 12% of currently married women in Bangladesh have an unmet need of family planning, and 7% for limiting purpose, and 5% for spacing purpose. And Bangladeshi women have 0.7% children more than their desired number. This implies that the TFR would be 30% lower if unwanted birth were avoided. Overall pregnancy termination rate, that is both MR and abortion in Bangladesh, 37 per 1,000 women of 15 to 44 years age group, which is higher than the equivalent rate of South Central Asia in 2008, and similar to the Southeast Asia. So next slide, please. Uh, 43% of unintended pregnancies are attributable to incorrect or inconsistent contraceptive use. That is the discontinuations. Next slide, please. In Bangladesh, challenging issues for family planning programs is most important: adolescent pregnancy. 25% of TFR is contributed by the adolescent pregnancy, and stagnant TFRs with regional difference of TFR is another problem for family planning programs. And also the low use of long-acting reversible contraceptive, and high discontinuation rate, high unmet need for contraception, and male participation in contraception is very low, and shortage of skilled human resources addressing hard to reach area. We have some hilly areas and some coastal areas, and some the island areas. So these areas is very distant areas where the healthcare provider do not want to stay. So retention problems is high there, the manpower retention. So addressing hard to reach areas is also a challenge, and especially the urban slum areas. The slum areas is a problematic areas for family planning program, because this program is conducted by other ministry, not the health ministry, and the quality of care is very much challenging, because in Bangladesh there are many client, but the service provider is not that much in quantity. So one provider has to see more client, has to give services to a huge number of clients. Next slide, please. Ongoing family planning programs, we are going through the HPNSDP program, Health, Population and Nutrition Sector program, which will end in June 2016. Orientations of long-acting permanent methods for obs and gynae professional. These are the ongoing programs of Family Planning Directorate, and increase awareness orientations on long-acting permanent method, projection by client segmentations at Upazila levels and managers and field level worker. In what we did, we conducted the local level planning with the local level manager below the sub-district levels, and they projected their target, and according to they make the plan, and then they do their activities according to this plan. So the Family Planning Directorate have also ongoing workshops, many workshops at the Upazila level for satisfied with the satisfied NSB client or IOD client, to make them encourage others eligible couple to take the permanent methods or the IOD methods. Orientations and training of doctors and paramedics from government and non-government organizations level to increase the postpartum LAPM activities. In Bangladesh, most of the delivery take place at home, 62%. So postpartum family planning is a challenge for Bangladesh family planning program. So we are orienting the doctors and paramedics from government and non-government sectors to increase the postpartum family planning methods. Next slide, please. These are the some initiatives that has been taken other than the regular programs. We have targeted to share 20% of LAPM in CPR, with 7% share of tubectomy, 5% share of non-scalpel vasectomy, and 4% share of IOD, and 4% implant. So bottom-up projections are being done based on the client segmentation and Upazila level. We think and this will be help to reduce the discontinuation rate, and special effort in achieving desired LAPM performance in hard-to-reach areas and low-performing areas by deploying roving teams of Mary Stopes Bangladesh. This is an NGO. So where we could not retain our service providers, we usually take help from Mary Stopes, and Mary Stopes Bangladesh, and they send their team there to do sterilizations operation. And postpartum family planning methods and MR menstrual regulations and post-abortion care family planning services has introduced in collaboration with a Director General of Health Services Engender Health of Bangladesh and IPAS Bangladesh. And satisfied non-scalpel vasectomy client workshop conducted throughout the country to encourage the other to take the vasectomies method. And we put emphasis more on NGO-GO collaboration, and also we have put emphasis on quality of care by following the SOPs and providing training to the service provider, refresher training to the service provider, and also strong monitoring visit. Next slide. I think this is the last slide. And thank you so much for hearing.
Great. Thank you, Shamol. We really appreciate your presentation. Next, I'd like to present Anirudh Jain. Anirudh is a distinguished scholar with the Population Council. And I do want to let everyone know that we're running just a couple minutes over, but we do plan to address all of your questions that you've been sending during the Q&A. So we might just go a little bit past 9, but we do encourage you to stay on the phone and keep sending us your questions. So now I will pass over to Anirudh.
Thank you, Arika. Can you hear me now?
Yes, we can hear you perfectly.
Good. You have heard a nice presentation from Ian, Sarah, and about Bangladesh. We know that family planning programs have been experiencing a phenomenon that I like to call the leaking bucket. Let's say that you place a bucket under an open tap and watch the water level rise until you discover a hole at the bottom of the bucket. Water is now leaking out. So filling the bucket will be easier once the hole is plugged, and that's all about the discontinuation. This slide shows that women who want to regulate their fertility and start using contraception join the pool of users like water in bucket. But many of them discontinue the method they initiated and leave the pool of users through that hole in the bucket at the bottom. We should note that all women who discontinue a method do not continue to have unmet needs. Some of them don't. Only a part of them continue to have unmet needs, and they join the pool of unmet need as past users. So unmet need consists of two groups of women: never users and past users, women who have used a contraception, initiated a contraception, but gave it up. Remember that past users or women who initiated using contraception have already overcome all the known barriers to contraceptive use: distance, cost, cultural barriers, objection of husband, objection of family members, objection of communities. So these group of women have come forward to start contraceptive use, but then family planning programs forget about them. So it will be easier to reduce unmet need if the this hole is plugged, and family planning programs pay attention to the reproductive health needs of women who have already overcome all these barriers and start using contraception. Next slide, please. Now, this slide sort of quantify the contribution of past users to unmet need, and is based on a study which I conducted with Ian and other colleagues. Past users account for, this is based on 34 countries, 38% of current unmet need is accounted by past users. So that means out of 120 million, the top two columns or bars, 45 million are past users and 75 million never users. That's the contribution to current unmet need. We also found that 90% of women who have ever used contraception will discontinue and continue to have unmet need in the future. So if we apply that number to current users of 258 million, then these 258 million women will contribute another 49 million women to unmet need. So in a sense, the total unmet need would be 169 million, and out of that 94 million is going to be due to past users. So FP 2020 goal of 120 by 20, yes, we can reach it if we push through family planning program and focus on helping women to initiate contraception and especially sterilization and implants, but that certainly is not a good strategy. But the goal can be reached faster if FP program also empowers those who have already initiated contraception to continue using any method, not necessarily the method they selected. And here I just want to point out that it's not the screening of women, it's not finding a woman who is suitable to a particular method, it's finding a method or combination of methods which are suitable to a particular woman's reproductive health need. Next slide, please. Now, this kind of symbol, who travel in at least in the United States and Britain and other places may have seen in the subways and train stations, which warn the rider to mind the gap or watch the gap between train and the platform. And I found every time I see it, it reminds me of this slogan that you have to reduce the gap between discontinuation of the original method and initiation of the same or a different method so women do not have unintended pregnancy in between. And I hope that someday this kind of a symbol will be placed in each family planning clinic to remind providers as well as women who are coming to initiate contraception that they have to worry about the gap between discontinuation and starting the new contraception. I would like to make two additional points if I have a few minutes. Yes. We hear a lot about the reasons for discontinuation, that the majority of women discontinue due to side effects. Now, just want to remind all of you that this is like numerator analysis. We are just looking at the distribution of discontinuers. We don't know what the base is. So we do not know how many women who experience side effects continue and how many of them discontinue, and why one group continue while why another group doesn't continue. So my plea for the future studies is, if we are doing any prospective study, that we find about the side effects, experience of side effects for both groups, users and non-users, and then see who discontinue and who does not discontinue. Now, what can be, second point, what can be done to reduce discontinuation? Sarah has listed a number of interventions, and many of these interventions are useful and common sense. The question comes is, what kind of evidence we are willing to accept about an intervention? If it is only the evidence which is based on quasi-experimental studies, then we have very limited evidence about how to reduce discontinuation. And my plea for FP 2020 would be to initiate some of those quasi-experimental studies in which you can look at the effect of intervention, group of interventions on discontinuation. On the other hand, if we are willing to accept evidence based on longitudinal studies, like we did in Philippines and Senegal, then it's quite clear that providers must provide accurate information about the method, how to use the method, and especially about the side effects and how to manage them, and possibility of switching at the time of initiation. So it is not finding women who are discontinued. It's spending time women who are coming to the facility or service delivery point in terms of how we prepare them for the future. If we go down, if we are willing to accept evidence from cross-sectional studies, then of course expanding choice of method by methods not available in a country or an SDP is an important intervention. And here the question is not about increasing the number of methods, but to provide different types of methods to, this includes short-term reversible, hormonal, non-hormonal, LARCs, and permanent methods to meet needs of different subgroups of women or with different reproductive health needs or changing reproductive health needs of the same woman. So some of the presentations on discontinuation, including mine, may give an impression that if we just switch the method mix towards LARC and permanent method, average discontinuation will be reduced. Yes, but then the reproductive health needs of many other women will not be served. So that's the point of caution from our studies as well. Thank you.
Thank you, Anirudh, for those excellent recommendations and the very, very clear presentation. So now we'd like to begin the Q&A portion, and we have received a number of questions already. So I'll go ahead and read those off. But I do want to tell the participants that if we don't get to your question today, as I know we're already running over time a bit, we'll make sure to answer those on the FP 2020 website. So you can visit the site that I gave you earlier, www.familyplanning2020.org/discontinuation, to be a part of the Q&A, to post questions you maybe think of later when you're reading the report, and we'll do our best to respond to you. So the first question I have here is from Sarah and Ian, and apologize on my pronunciation. This is from Leila Aklagi, and she asks, are there discontinuation rates different? Are these discontinuation rates different for those used to calculate CYPs, especially for longer-term methods like IUDs and implants?
Sorry, are you going to read through the questions, or would you like us to respond one by one?
It would be, oh, sure, Sarah and Ian, if you could respond to that.
Ian,
that would be great.
Quantitative man.
The rates we presented were taken from analyses by Ali Shah and Cleland, which use DHS data. So these are different than calculations used for CYP.
Thank you. And another clarification question that we had was, does the discontinuation rate include those who may have switched methods?
The rates are based on questions asked. Yeah, so the rates are based on questions asked of women who have stated that they've discontinued, meaning that they've stopped. For the switching proportions, those are a combination of questions that pick up women through the calendar method used by DHS.
I think it's. Can I just add? I think it's true. It's true that it's quite complicated, as I think you get the those who stopped and just stopped, those who stop and switch, and those who use inconsistently, and those who stop but don't consider themselves stoppers, which is the case of many people who are sort of a bit ambivalent about it and can't be bothered to go back at the right time for their injection, for example. So I think the whole categorization of between stopped and switching is full of quite interesting nuances that we don't perhaps fully understand.
Can I add something to this?
Oh, please do.
I think these rates which our Ali and group have calculated, these are based on episodes, not women. So switching is not included. This is first segment rate. It's not all segment rates.
Great. Thank you very much. So here is another question for Ian and Sarah. This comes from Jawara Saidiakan, who asked, did we find out what proportions of discontinuation is due to pressure from spouse?
I don't think, shall I answer that? I don't think we know that exactly from the data because I don't think it's something that is kind of routinely measured, and I'm not sure that you could actually get at it quantitatively. It might require some more qualitative work, but I think the whole notion of spousal relations and communication around, first of all, contraceptive use, and secondly, discontinuation is very complex. And I think, you know, some women might wish to continue despite their spouse wishing them to stop, and vice versa. And again, in certain settings where you have low prevalence and poor spousal communication, you might be looking at women's, to supporting women's clandestine use. But I think the spousal communication side of it is very important, and we did cite some studies that show if the spouse is supportive, then the continuation lasts for longer. The question remaining is, if he's not supportive, what strategies are open to women to still be able to continue despite husband's opposition?
Great, thank you. The next question is for Shimul, and it comes from Suya Wang. She says the IUD continuation rates are quite high, so why hasn't the government of Bangladesh promoted IUDs more?
Yes.
Shimul, can you please address that question?
We are trying to increase the user rate of IUD, but you know, it needs skilled professionals, and also need some privacy, and also need prevention of prevention of infections. So there are some limitations. Before some 6 months or 8 months before, we have lack of providers, that is family welfare visitor who usually provide IUD, but we have recruited about 600 FWB providers in last 6 months. So I think we would able to increase the user rate of IUD. And another problem, some of the areas, those who are very much conservative, they think that keeping a foreign object inside the body is forbidden by the religion, because if they the women think that if they die, they will not go to heaven if they keep these foreign bodies inside the uterus. So I have talked so many women, especially in the remote areas, those who said like this. So anyway, I think in future we can able to increase the user rate of IUD. Thank you.
Okay, great. And then just if anyone would like to respond, we have a question from Gilda Sedge. She thanked everyone for their excellent presentations and noticed that one of the initiatives at the end of Shamil's presentation was an increase of the use of long-acting reversible methods to 20%. So she asked, how do we reconcile method mix goals with the overall goal of ensuring contraceptive choice? Is it possible that long-acting reversible methods do not fit the needs and wants of enough young women to achieve this goal? And that's for anyone who'd like to answer.
I can take a crack at that. I don't think anybody has, I mean, this is kind of a mistake to have a goal for method mix. It's a goal for how many methods or what type of methods are added to the program. The use has to depend upon what is the best interest of women in that country, and what they use within the context of their own religion, culture, family, and whatever. So you cannot have a goal that we will have 20% IUD users in one country or the other. It's like having a goal that a surgeon has to have 20% heart transplant. If there are no users of that particular surgery, you cannot set that kind of goal. So in a sense, the goal should be set in terms of making multiple type of methods available. That's the choice. And within that context of choice, what method is selected has to be dependent on what women like or don't like at that time.
Thank you, Anirudh. That was an excellent response. Now, we are receiving many, many questions, and I realize that we could take up the whole day asking our speakers to address various questions, but what we will do is collect all the questions we've received and post them on our website, and then we'll work to answer all of those as we can. So we are past our time today, so I would just like to wrap up by first thanking our speakers, Ian, Sarah, Shimul, and Anirudh, for their valuable insights both during the presentation and in the Q&A. I'd also like to thank all of you for taking the time to join and for sending these really excellent questions. And I'd like to recognize my colleague, Rati Bishnoi, for managing the technology today. This can be really tough, and she did an excellent job. Today, Ian and Sarah have laid out some very interesting recommendations to the community, all of which you can read in the report that is now on the website listed on our very last slide, which is www.familyplanning2020.org/discontinuation. In the coming days, we will be adding additional resources to this website, including this presentation, the webinar recording, and the Q&A. We hope that you've enjoyed the presentation and that you share the report with your colleagues, and have a great rest of the day, and thank you again. Goodbye, everyone.
Thank you.
Thank you. Goodbye. Thank you.